So it's my real pleasure to start session 2 with a fantastic speaker. She is one of the pioneers in longevity medicine, and she's in fact one of the organizers of the Longevity Medicine Day, the main organizer, the chair, Professor Evelyne Bischof. Give her a hand, please.
So thank you once again for everything. I'm really sorry that we are late, but at the same time, I'm really happy. I almost thought that it would be the case because we have amazing speakers and great discussions. But I will try to cut my sessions short so that we will have more time for the honorary guests and for the panel discussions. So thank you, Morten, for introducing me. My name is Evelyne, and I'm internal medicine physician and oncologist in Shanghai, China. And I'm very happy to say that I know that many of the colleagues from China are watching, so thank you so much and welcome. And also friends from Israel, the rabbi, thank you very much for watching as well. Myself has been, in longevity medicine for the past 3 years about. So when Professor Kinkler mentioned that, I was thinking that when I saw what medicine is implementing in terms of AI and innovation, and when I tried to, make the bridge between oncology, aging and oncology, cancer science and mechanisms of aging are pretty much most intersected and related ones. And when I started also to learn the language of the AI scientists and computational scientists and geroscientists, which was very hard as a physician, I realized that longevity medicine is a field that is so fast, and it reminded me of this one quote that you have to actually run double as fast in this field to move forward. Otherwise, you have to just constantly run in order to just keep up with the pace, keep up with all the amount of large information. And myself, I'm in China, and I have to say that it was a conscious choice to be there because it is one of those places in the world where innovation is in there already, and it's been there for the past 7 or 8 years at a level that I have not seen maybe in some other places I worked before. The maturity of people, of the society towards AI is so high that we are already living this type of hybrid medicine. So most of my longevity patients, besides of me working in a hospital, in a very traditional sick care setting, most of my longevity patients are there because this type of, I wouldn't say telemedicine, but this type of high-level integrated 24/7 monitoring and interface is something very typical and something very easy and natural for them already. And I had the great honor to be invited as a contributor to the paper that Dr. Toad mentioned in the beginning of our session in the year 2021 with Dr. Kaifouli and Professor Javeronkov on longevity medicine. And we did try to define the field as per request of the editor, but it is merely a stimulation, merely a thought and a very overarching attempt to define something that is constantly evolving, that is a perpetuum mobile, and that we will be trying to define better and more broadly and also more granularly with the Longevity Medicine Society. But what we tried to, let's say, frame in one sentence was that longevity medicine is an AI-driven branch of medicine, individualized medicine, that is specifically focusing on health span. And I have to underline once again, we heard that today, but I would like to repeat it, longevity medicine is not about extending life. We are not focusing on the lifespan. We are focusing on the healthy lifespan or on the health span. The years lived in good health. And it is an ongoing learning. So what I'm seeing in a practice with my longevity patients is that we are constantly learning and trying to translate what we see in the studies to the patient, but in a very, let's say, as much as possible credible way, which at this moment is still not fully evidence-based. But we are using the tertiary digital layer of the patients that they are constantly giving us. So the monitoring, the diagnostics on a very high level. And partially also this cybernetic collective programming of the AI that we are doing together with the patient is something that I am living every day. I learned a lot from the patient. I learned a lot from what they are finding, and I'm learning how much they are willing to risk in order to potentially improve their health span. So there is a very interesting debate that we are having right now. How much of a risk is the person willing to take in order to potentially add the life into the years? But at the end of the day, it's always a combination of artificial intelligence and human intelligence. So I'm not one of those physicians that says that AI will, one day replace us. The opposite. I think we should always look at the positive side, and we have right now solutions, enhancements of our practice that are tremendous, and that when I was studying medicine, it was a dream. And being in China especially taught me that having also the willingness of people to participate in this type of movement, so the maturity towards AI of the society is very, very important. And of course, also the level of science. So the support of physicians from the scientists is very important. Learning how to communicate with each other, and them being willing to listen to what we need and what our patients need is very important. And why do we have this word AI always in between? I believe mainly because we have to remember that with the machine learning and with deep learning, even if it's not perfect, I guess nothing is perfect, especially not in medicine, but what we have right now is a tool, at least, that can help us to evaluate, to analyze, and to get objective trajectories from all those retrospective data that we have, and also to teach us how to collect properly prospective data, longitudinal data on healthy individuals, so that we can make sense, find biomarkers, find trajectories from this multimodal, extremely heterogeneous data that we have, that would include everything from the basic omics, proteomics, transcriptomics, genomics, through all the system levels, right, biology and physiology, through the genetics, and then also through all the hormones, basically all the ways of the systems, organs, and then not to forget also the epigenetics, and of course, last but not least, also the neurodegenerative, the cognitive, and the psychological components of it. And I guess we all agree that the human intelligence is not able to grasp it all, so we need this enhancement to help us to make the best towards an individualized medicine in a, I call it always tri-dimensional sphere, that we look not only at the individual person, but also at the individual person in a specific setting at a specific time. When we achieve that, this is, I guess, also, once again, dream come true for a physician, how to guide and lead and help a patient at a specific point of time. And when I say a patient, I'm one of those people who consider aging as a disease. It's a debate, but patients for me is pretty much everyone who is experiencing aging. So I include myself into it. And I will have to skip you a few slides, as I mentioned, in order to give room for other speakers. But what we do in longevity medicine at this moment is basically to use the tools that we have, and those include biological aging clocks, those include those biomarkers that we have, and those monitorings that we have, and the data that we can collect or have already from the patients to calculate what is the biological age at this point of time for this specific patient, what would be the optimal biological age of the optimal performance of that patient, and try to also restore that age so that the patient will not get to the point, like Professor Sierra mentioned, the frailty point, or the point that there is no return. So we are moving like a few steps ahead from the prevention medicine that is helping us to detect the disease at an early stage to detecting a risk of ever developing a disease, and hopefully at some point of time also not to only mitigate those risks, but also to eliminate those risks. And we are doing that by, right now, collecting a lot of data. So longevity medicine, for me, I like to think in sectors, very German. So longevity medicine has two legs, from my view, the diagnostics and the therapeutics, or the interventions. And we all know that at this moment, the intervention leg is still very, very weak, still growing, but the diagnostic leg is pretty solid. And there is very often this argument, why should we do all these diagnostic tests, those monitorings, if there is nothing as a consequence? You know, in a sick care in a hospital, we always say, why would you do this test if there is no consequence? Consequence means intervention. And in longevity medicine, I would say it's a bit different. In order for us to actually identify the biomarkers and then later on to validate them, we need to have the data. So human longevity is just one example of a diagnostic setting that is collecting a lot of data, and I just use it as an example. There's many other centers existing and building up that are doing the imaging data, that are doing the omics, that are doing all the other functional and physiological testings. Bottom line, a large amount of data. So for every patient, every 150 or more gigabytes and more tests are on the way and available on the market. And not only has the patient get the opportunity to come somewhere to get the diagnostics, most of those people do it already by themselves. And most of those people can track their health also and collect reasonable amount of data at low cost. So we are not talking only about the high-end concierge services, but actually people that are collecting their data and are trying to already build up their longitudinal data set so that the longevity physician, that hopefully more and more of them will be coming, can make a sense and lead this patient towards healthy longevity. And this clinical precision diagnostic, of course, includes genetics. Here I would like to just mention the point of polymorphic risk scores that are there, pharmacogenetics and pharmacogenomics, and of course, all of those data then being fueled and hopefully also at some point of time giving us better understanding and better material, better base for developing of AI-based aging-targeted drugs. I would like to mention some of the monitoring panels that we have. Most of the longevity patients can already be equipped with a reasonable amount of monitors and sensors for every day, from CGM through 24 hours blood pressure monitorings, through liquid biopsies that we will be talking about in the last panel, in the urine, not only in the blood, and in other liquid samples that are not invasive. And all of those data will hopefully help us at some point of time to develop something that is so extremely sought after and not yet validated, not yet existing. I would like to point that out, and I know Professor Maier will support me on that. There are no validated guidelines in longevity medicine yet, and no guidelines that would tell us how to diagnose, what to diagnose, and protocols in place. But we are on the way, and it will happen, hopefully soon, if we work well. And we will be able then to develop something that would be like a longevity protocol to say for a specific person, a specific point of time, what should be tested, when, how extensively, and in which granularity. Deep aging clocks will hopefully help us in that as well. Professor Zhavarenko is one of the leaders. It is a tool that definitely I'm using, and some of my colleagues as well, but there's also, of course, there is a variety of other clocks, and this is great, and more are coming. One of them is now being developed in Mayo Clinic, the cardiological aging clocks, and many others. It is already helping me, for example, with my patients to not only to very reasonably demonstrate the biological age of the patient, but also to know what should be precisely changed to which amount. And especially educating the patient to shift from the regular understanding of the ranges that we have in our medical setting based on populations and RCTs that were done before in 50s and 60s, but to a precise demonstration of which markers should be changed how much for patients. And I would like to also demonstrate an example of a person that tried to intervene longevity interventions on himself, taking a very large amount of NMN and a large amount of rapamycin and some metformin, leading actually to the exact opposite. The biological age at his chronological 40 was 44. And increased later because there was no change even after a year in the interventions. Now this age decreased to the chronological, it's 42, the same like the biological and chronological decreased after stopping some of those improperly used interventions. So there is a risk. There is a risk, and as a physician, for me, the number one is do no harm. So if I have a patient who is even, so eager and willing to try something, there is some level of the physician mind and the sick care knowledge that we have that should be implemented. So bottom line, longevity physicians are important, even though potential protocols are publicly available based on case studies or anecdotal examples. And this is just an example of a longevity plan. So a patient that is being tracked, that has a list of supplements, that has a list of diagnostic that is being done, led properly, has not only maintained the biological age for the consecutive 3 years, but actually also now got a rejuvenation of -1 year. And it's great for me as a physician to hear the feedback, to see that the patient is feeling well, looking great. That's great. I'm happy about that. But I like, as an academic physician, to also have a measurement. I need to see that it's really happening, that it's not biased or placebo-based. So this is why those biomarkers and those biological aging clocks are actually very helpful, personally, for me. Cerebral health, I would just like to mention that it is also something extremely important. We will not have enough time to debate it in depth, but not only neuropsychiatry and neurodegeneration are important, so the quantitative measurements of the brain health, but also, of course, the mind, so the psychological age, are of great importance. And of course, as a physician, I like to measure them, so I'm very happy that beyond credible surveys, we are now also seeing good developments in NLPs and other ways of quantifications in that field. And there are new frontiers also in brain biomarkers that are there, not only based on the imaging, the measurement, the brain age, for example, but also in liquid biopsies, again, in fluids. Last but not least, I would like to mention something that is a huge passion of mine. It's the education. So being, a professor and teaching medical students, it's something that I always loved. But to educate even now fellow physicians in longevity medicine is such a huge pleasure and such a great honor. This is a publication that we were happy to publish in Lancet Healthy Longevity about 2 years ago, right? Also with Morten and other colleagues about upscaling the longevity physicians. And as Professor Javaronkov mentioned at the beginning of the speech, we have the course that is for free for physicians. And the great thing is that also not only our introduction course, but the advanced course has been approved by the CME. And there is a small quote from our... Oh, there's no sound. There's no problem. From Professor Barzilai, who commented...
And I took the test. And I think there's nothing like that, and there's nothing that's done as well as this is done. And I think it's just so important for the field. And
Thank you.
Thank you very much. And
So yes, so we had. It's great to have feedback from such credible and important people in the field, like Professor Barzilai, who also took the course, commented on the course, took the course, of course, not because he needed, but because he tested and gave us feedback. So it's really a great passion, and there will be a clinical part that will be coming up, and this course is available in Chinese. 我们也有一个中文version. And one can get educated. So with this, I would like to conclude and say that I'm very, very honored to be here. I will take any questions at the end of the session and would like to, without further ado, go to my next speaker, a great colleague that we have been working together for like over a year or 2 years, virtually. Saw each other for the first time in person today. Professor Andrea Maier, who is leading the Center of Healthy Longevity at the University of Singapore, that is a tremendously accomplished internist and geriatrician, and the president of Longevity Medicine Society that was created just a few days ago. Welcome.
Thank you so much, Eva. And it's not 2 years. You are aging very, very fast. It's 9 months. Because I know I sat here like a year ago and I said, okay, we have to do something. We really have to create something special, something new. And then I contacted you, I think, 2 months later. And now we have a Longevity Medicine Society. So my title is Introducing Longevity Medicine to the world, I would say. I think really as a healthcare professional, I managed lots of hospitals, was the head of geriatrics, and I moved to, in different hospitals, moved to Melbourne and tried to really convince cardiologists, endocrinologists, etc. to change their care as a divisional director, and I failed massively, I would say. So not that managing is not good, but I was not satisfied. I was not satisfied that we are treating individuals when it's already too late. So I'm an internal medicine specialist. I did lots for accreditations, etc., for internal medicine and for geriatrics in the Netherlands and in Germany and in Australia. And so I know how the business is going, but I was not satisfied as a physician. And why I was not satisfied as an internal medicine physician, I'm still not. I'm still an internal medicine physician and geriatrician, but I would call myself now a longevity medicine physician, because medicine is black and white, or it's black and red, or it's black and a dot. And everything what's a green of a dot or red is what we call always abnormal. And then we say, yes, it's abnormal, we have to do something. Whereas in medicine, everything which is not bold or not black is normal, and we don't care. I would say, okay, everything is okay, blood pressure is still okay, go. So what we don't take into account is actually a trajectory of life, our trajectory. If you have a baby and a newborn, you will measure the weight and the weight and the weight until, in different countries it's differently, to certain ages, and then you stop. And I think that's bad, because we know from the age of 20 onwards, we are declining in our organ function, which you know. And at a certain time, we as physicians, we say this is abnormal and this is normal, so it's dichotomized. And I, as a clinician scientist, I don't like dichotomized things, because I always tell my students, don't throw away power of your data and make dichotomous, so 2 groups or 4 groups or whatever, but use your data continuously. And that's what we try to achieve in longevity medicine. So what do we already a little bit do, and especially GPs do that? If you have a 60-year-old, that 60-year-old is declining in the organ function, the glucose is going up, the blood pressure is going up. Before actually we hit that boundary, that cutoff, we defined super duper well that this is abnormal. We try to prevent these individuals to cross the boundary. And that's what we call prevention. And then we say, yes, well done. Diabetes is delayed for another 2 years. What we don't do is in the same 60-year-old who is functioning very well to actually see if you would be your digital twin, would you be even better? Have you ever asked yourself, are you in the greatest shape you could be? I'm not. I can tell you. I tested lots of clocks and whatever value they have, but I am not. But I'm trying. And I think realizing that maybe I'm not in the best shape and I have something to gain would also be very useful for the ones who are in the best tertiles or in their quintiles or whatever, the best of the best. We would say, don't come to the GP, don't use my time because I'm there for the sick. So we don't dichotomize you're not sick or you're sick, but also look at yourself and can your body or your mind and your soul even be better? And that's very new, I would say, in medicine. So that's in a 60 or 70-year-old. But what we absolutely not do, and it's my age group, we are not looking in the 40s. So you're already declining, and you see that. If I look at the mirror, I think, okay, I have to go to the airport and get another cream with bubbles, and they say, I feel better, but it doesn't help. So already at the age of 30 or 40, we really have to look at what could be your capacity. And could you actually get that up, that your slippery slope to dependency might be a little bit later. And that is really what longevity medicine, we will have a consensus meeting next week actually in Singapore, what longevity medicine actually is. But this is at least what I think longevity medicine is. To really bring the best out of, if that person wishes it, out of that body. And of course, I said, okay, at the age of 20 to 30, maybe we should start even earlier. So we do projects in NUS where we actually look at the health of the mothers before actually conception to optimize the health of the child. So you can really think even more dramatically and differently at a person's health, because in the end, we are a genetic composition with lots of epigenetics, and as Mahmoud Khan already said, the environment is shaping us. That was the reason that the healthcare system and what I was managing is so different, that I thought, okay, I have to talk to lots of people and let's bring like-minded people together. Because if I say, and that was also my failure, I would say, in Australia, and I'm very open to that, I wanted to have longevity medicine introduced into clinical care, but I couldn't do that because there was no basis, there was no surrounding. So we need each other to grow the speciality. I'm not a physician in the wellness sector or giving treatments which are not evidence-based, but I couldn't implement it because there was not that basis. So now we have, and I just had a print screen this morning, the Longevity Medicine Society. As Eva said, we were founded at the 8th of the 8th, 2022, which is great. You see on the right-hand side, it's very important, the most important part of this talk, that's membership. Of course, you would like to know what you get of being a member, but there's a membership. So just look at the website. It's longevitymedicinesociety.com, and then you find all the information. Of course, the website could be even better. There could be other colors, but we have a website, and that took us 9 months. Who is the Longevity Medicine Society? Actually, we have 6 members, which is great. So these are the 6 founding mothers and fathers of the Longevity Medicine Society. The first meeting, the physical one, we had lots of meetings. And I think we will still have our Sunday meetings every Sunday with Eva on the call. How do we do it? How can we open a bank account? How do we get the website? That's great. So the first physical meeting to actually define what is longevity medicine is next week in Singapore. What do we do? I like to be very short and that you memorize what we want to do. Very simple. We want to educate, we want to improve, especially quality, and we want to accelerate. Education, very dear to my heart, and lots here in the room already do lots of things for healthcare professional education. I know that, and we heard about the nice courses, I know that lots of universities already have masterclasses. We also have now a masterclass, or will have very shortly a masterclass at the NUS. We are establishing executive masters, etc., etc. I think for healthcare professionals, we have already something in hand, but what we don't do yet, well, I would say, is coming together to say, okay, what should we teach? And where is the harmonization of what should we teach? And that is not that we will have a master class of the Longevity Medicine Society, but what we can do is bring people together who love education and to talk and to come up with a little bit of a guideline how far you go and what certain certificates actually mean. I think it's very important also to educate policymakers, to educate CEOs, for example, of hospitals, who really have to, in the end, if we are successful, have to implement a new speciality into their programs. And I think also knowing what they should know is very important in defining that. Very dear to my heart is layman education. As we already discussed this morning, if there is a crowd of people who really want something, they can move the field. And we see that in rare diseases, especially in children. So we really have to try to build that relationship. And it should be a friendly relationship with laymen. So media really helps. And I try to do that often in Europe, but I think we need much more of us doing so. And I think also we need to educate ourselves what kind of keywords we use, what kind of methods do we want to bring across. I think that's very important. In the end, the education should lead to lots of longevity medicine physicians, I would say, which means that we also need a guide or a framework of certification, etc. So I'm with the government in Singapore already, with the medical council. I'm in contact to prepare them, etc. And I know that lots of others in other countries also do that. So the society brings these people together to create that new speciality that we can practice in the end, under the umbrella, maybe first of all, of internal medicine or geriatrics, and then into the GP practices or into endocrinology, etc., up for shaping the future. Very important, I find, and I think there's also a risk of our field, is that we have to come together to improve what we are doing and how we communicate. And I think improving of quality, what I learned in other specialties I work with, is writing guidelines, which are accepted, and that's very important. I don't know if I haven't heard of any guideline yet in the longevity medicine of what we are doing on a daily basis, what we are doing. There is nothing. If we don't have guidelines, we have no quality control. So what kind of biomarkers can we already implement in clinical practice? What kind of aging clocks? Do we have any ratings? No, I don't know. Which interventions are safe? Where is the evidence? So we have all the ratings. I was in lots of guideline commissions in my life, especially in geriatrics. And I think we just have to apply them in our field. And I'm not afraid that we will have lots of no evidence. But then we know that there's no evidence, and we have our new research plan we will discuss with foundations, and we can actually fill that gap. So that's very important. So standardization guidelines, which we need to bring the knowledge to the field for the layman, because the average person who is contacting me by email to say, which clock should I do? Which intervention should I do? Where should I get my metformin? Where should I get my AKG or my spermidine or Fisetin or whatever? How many strawberries should I eat? We need that guidance, not only for the healthcare professionals who want to be in the space, but especially also to our clients. I call them clients and not patients, but I think this is also up for discussion. Then acceleration. As already told, I'm 20 years in the field. I'm a little bit a dinosaur, but I don't see, but maybe I'm blind, I don't see that translation yet into huge trials, into huge networks. Everything I saw in the cardiology space, in the oncology space, everywhere where I'm looking, where I'm very familiar with, we don't have yet. So the translation from animal studies into human studies, I think, need to be accelerated. So that's also one aim. Not as a society, we will not have money for big trials, but what we can do is bring people together and actually see cross-country, cross-nation, how we standardize what we do in trials, and that we can actually do the trials together. So a trial network is really dear to my heart, and hopefully next year we will say, yes, we opened our, maybe not the first trial, but maybe we submitted the first ethics application. And I think it was so wonderful to hear from James Kirkland that actually this is already happening in the US. And what I also mean with acceleration is there are lots of people, I think also here in the audience, who want to set up longevity clinics. I got my keys for my own longevity clinic, a private one. I'm setting up now a public one in the hospital. I think we have to learn from each other. I can tell you, I'm in the field for a long time. I have lots of individuals I advise, and I am learning. And I think everybody here who sees clients who have a biological age clock in front of them, and it can be an epigenetic or based on metabolomics or young AI or whatever, I still learn. Sometimes I feel as a resident in my first years of my training. And I'm fine to say that, but I think lots of you might also have the same. So let's come together and actually change the ideas. So the longevity medicine summary, you just have to just one word. The membership is very important, and connecting each other to really bring the field forward. This is not that I have to teach you what geroscience is, but I want that every layman knows what health span and lifespan is. And I think we have to articulate that well in the media, etc., in every forum we are. And I think we have to learn which language we speak. This is also not that I have to learn you that everything is going down from your 30s onwards in terms of function. But I only want to show you that we have lots of cohort data with beautiful data. For example, here the Dunedin study, who have follow-up, who actually showcase evidence-based that organ systems are going down. I want every layman to know that they know from the 26th onwards, celebrating the 7th birthday, that very likely the T's are going down in function and more carriers, etc., and that the blood pressure is going up. This is a slide for healthcare professionals. What we learned from the UK Biobank, and in my academic talk on Wednesday, I will talk a little bit more about it. We can prepare healthcare professionals and organize care differently if we use the data well, having the lens of aging on. We just showed here that there is a sequence of diseases in healthy individuals, so we can predict what's occurring, which function is declining when, which means that we can interconnect the general of the healthcare system we have at the moment, a quite conservative one, so we know that the sequence, and we can standardize care, and we can be proactive to prevent the next age-related diseases when the first already occurred. And this is not for Mahmoud Khan, that everybody has this slide, but I want every physician that to know at least the 9 hallmarks or 12 or whatever, how many, but I want physicians to know, and every medical student, what actually the mechanisms of aging and the hallmarks of aging are, even if they're outdated, but we are updating. This is most important, and this is what I would like longevity physicians, of medicine physicians, to know before stopping. What, in my view at least, but also we have to learn, we have, as Eva already said, we have diagnostics and we have interventions. We already have, it's not like me in a memory clinic taking an MMSE, not having any drug and anything to offer at this moment in time. In the longevity medicine physician clinic, we have something to offer, and that is individualized lifestyle choices and changes. We can already extend, if you take the mean of a population, the health span and the lifespan by a couple of years. So what I really would like to see in many more talks next year, that we are diagnosing something. We are bringing that into the care for that individual. We have these interventions like environmental changes, very important. What is the noise level while sleeping? What kind of pillow do you have? These kind of discussions I have with my patients. Lifestyle choices, supplements, drugs, etc. And of course, then the new drugs. And that needs to go into a remeasurement to actually see if it worked out. So we have diagnostics in hand in terms of identification diagnostics. What we really have to do, we have to promote longevity medicine, and we need a better ICD code. I know there are lots of discussions in the field. I just touched on a little bit while using this slide that we are really promoting. And thanks to all the courses and the leads, Eva for bringing up this nice topic, that we need to be in touch with agencies and communicate, and that's also the role of the society, to give us the basis for our work. And this is a slide not to educate you that physical activity is good, but this is a slide to actually show you that we need collaborations. I think if I'm looking here in the room, I know 50% of the people at least from FACE. Don't ask me any names, I'm very bad in that. But what we miss is input and influx from the outer side. So we need exercise physiologists, physiotherapists, we need many more integrated here, dietitians, occupational therapists, etc., psychologists. So we have to invite individuals to join. So hopefully, Morten, where are you? We have to extend this beautiful building. And we need, once again, more trials. We have to translate from animals to humans. These are just as an example. Don't look really at what we are doing, but these are the trials we are planning, we are doing at the moment in Singapore, in different animals and in humans. It's a great opportunity, and I will really close, Eva. But there's also lots of risk. And I think the biggest risk is that we don't act now. I see lots of specialities, I must say and admit, I've never heard of, like 2 years ago, like functional medicine, wellness medicine, and lots of other words, which are also not well defined. We have to define what we are doing. We are living in a big bubble of a huge investment. I really agree with Dr. Khan, we are not ready, but we have to make sure that we are ready. So hopefully the 3 days will really bring us together and not thinking that we are working against it, we are working with each other, because this huge space is so huge, there's room for everybody. I just want to acknowledge also the foundations who spent lots of energy, I would say, in bringing not only money, but also lots of discussions to the field, bringing us together. It's not so much the money, but bringing somebody together. For example, advisory boards already helps the field. So thank you so much. Where is Gary? I haven't seen him. But for example, the Longevity Science Foundation, I think we heard lots about evolution, but I think their mission is spot on, and that's what we should do together. We already educate. We have webinar series, so if your Thursdays are empty in the calendar in your European time 1 to 2, or if you're in Singapore 7 to 8, follow our webinars. Every week we have a great speaker. Thank you all of you who are already in our show for participating and donating your time. We are launching our Center for Health Longevity. I'm co-leading with Brian Kennedy on the 7th next week. The Longevity Science Singapore conference, the first one, is aligned to that, and you see lots of faces familiar, so there will be a flight from here to Singapore, it seems. So we are spending a couple of days together there, and on the 8th we are opening our center also for laymen and for the public. And as you see, practice what you preach. Thank you very much.
As always, excellent, absolutely fabulous. We will have time for questions at the panel. And I would like to invite Dr. Joan Mannick, who is also a fellow physician that is very much involved now also in the industrial part on developing new therapeutics, primarily in aging. Joan, please join us, and thank you so much for being here.
Well, I'm delighted to be here, and I'm going to talk about the work we've done over the past decade targeting mTOR to treat aging-related diseases in humans and the lessons we've learned. So as most of you know, mTOR is a protein kinase that's an evolutionarily conserved mechanism that regulates aging. So in every species study to date, whether you inhibit mTOR genetically or pharmacologically, lifespan and health span is extended. And so since these are evolutionarily diverse species, it's likely that humans also are going to benefit from mTOR inhibition. So not only is the mTOR pathway very well validated, but one particular mTOR inhibitor, rapamycin, is the best validated therapeutic targeting aging biology in preclinical species. So again, in every species, yeast, worms, flies, and mice, this one drug has extended lifespan. And what's important is these findings have been validated by multiple different labs, which is very encouraging. So why does mTOR inhibition have these benefits for aging? Well, one of the interesting things is data in mice that showed on the study on the left was a very famous study published in Nature and funded as part of the intervention testing program by the National Institutes of Aging that looked at what happens to lifespan in mice who are started getting treated with rapamycin late in life at 600 days of age, which is the equivalent of about a 60-year-old human. And even late in life, rapamycin significantly extended lifespan. And then in the study on the right, this was done by Dudley Laming's group, where he showed even if you start rapamycin late in life and treat just once every 5 days, that's sufficient to extend lifespan. So why? Well, one of the reasons may be because mTOR becomes dysregulated with age. So mTOR is the main protein in the body that responds to feeding. And when young mice are fed, as you can see here, mTOR is activated. And when mTOR is activated, this stimulates protein and lipid synthesis that cells need to divide and organisms need to grow. And then during periods of fasting, mTOR is inhibited. And when mTOR is inhibited, this upregulates protective pathways like autophagy that gets rid of dysfunctional organelles and aggregated proteins. So mTOR should have this sort of circadian rhythm on when you eat, off when you fast. But at least in some aging organs in mice, mTOR remains aberrantly activated during periods of fasting. And so you never have these periods of the day where these protective pathways are upregulated. And this suggests that just turning down mTOR to younger levels or just intermittently inhibiting mTOR may have benefits for human aging. And with all of this pathway validation, the question is, why haven't we done more to figure out what mTOR inhibitors like rapamycin do for human aging? And in fact, there are thousands of people right now who are taking rapamycin, but we have no idea what is the right dose, what's the right duration, where does the risk-benefit actually favorable in which aging-related conditions. And to answer this, we have to do placebo-controlled trials. But there's been very few randomized placebo-controlled trials of rapalogs, which are rapamycin and its derivatives, for aging-related diseases. So why is this? Well, one of the reasons are safety concerns. As Jim Kirkland mentioned, when you use rapalogs at the doses they're approved for cancer and transplant patients, these are high doses that completely turn off mTOR and have significant side effects. What really hasn't been well studied, I'm going to talk about some of the studies, but is the safety and efficacy of very low dose or intermittent doses of rapalogs that turn down mTOR to younger levels rather than turning it off. This is a really exciting area of medicine, and really we have only scratched the surface and so much needs to be done. The other issue has been patent concerns. So the current rapalogs have limited or no remaining patent life. And that, hopefully with evolution won't be a problem anymore, but right now to get investors, it's really tough to get investors to invest in very expensive clinical trials for drugs without patent protection. So you could say, well, let's just generate new rapalogs. But this is incredibly difficult because the rapalog patent space is so crowded. So with these problems in mind, Novartis put a team together to develop next-generation rapalogs for aging-related indications. And they didn't just want another rapamycin, they wanted something better that also had patent protection. And they put some of the best rapalog chemists in the world on this project, and they developed a portfolio of novel rapalogs covered by 3 patent families that's now been out-licensed to Tornado Therapeutics, which is a company that I co-founded with James Pyer at Cambrian. And we're excited because preliminary characterization of these compounds by Novartis indicates the lead compounds have distinctive characteristics that are predicted to enhance safety and efficacy as compared to the first generation of rapalogs for specific aging-related diseases. We're just starting to move these into development, so I'm going to spend the rest of the talk discussing trials we've already done in humans, looking at how we could use the first generation rapalogs to treat aging-related conditions. So when we started this program a decade ago, we thought, how do we tell if rapalogs have benefits for human aging? And we thought, let's look at the organ systems whose function gets better when older animals are treated with rapalogs. And the function of some, but not all, aging organ systems gets better. So neurologic function gets better, and again, it's reassuring that this is reproduced by multiple groups. Cardiac function gets better, physical activity gets better, and aging-related immune dysfunction gets better. And we decided, as our first look at whether mTOR inhibition helps human aging, let's see if we can improve the function of the aging immune system, because it's an organ system whose function we can modify in a relatively short clinical trial time frame. So there's several potential benefits of developing therapies that improve the function of the aging immune system. Most obvious is that we should be able to improve vaccination response and decrease infection rates in older adults. But also, we now know the immune system is important for cancer immunosurveillance, so a drug that improves immune function may decrease cancer incidence. Third, you heard a lot about the problems with senescent cells from Jim Kirkland. The immune system is needed to clear senescent cells, so enhancing immune function might decrease senescent cell burden. And last, a really important paper was published last year in Nature by Laura Niederhofer's group, who showed if you just age the immune system in mice, other organ systems start to age. So the immune system may drive organismal aging, and inhibiting immune system aging may have more systemic benefits. So we started by saying, let's just see if we can improve vaccination response in older adults as a first readout of immune function. And we did 2 phase 2A trials that have already been published, showing that if we treated older adults with 6 weeks of different mTOR inhibitors, we used 2 drugs that were already in the clinic, a rapalog called everolimus and a catalytic site mTOR inhibitor called RTB101, we could improve influenza vaccination response. So this was exciting because it was the first evidence that targeting aging biology in a human could actually improve the function of an aging organ system. We then said, why? Why is the immune system getting better? So we did non-hypothesis-driven RNA-seq in whole blood and looked at what are the gene expression pathways that change in older adults getting mTOR inhibitors. What was unexpected is the majority of gene expression pathways that were upregulated in older adults were interferon-induced antiviral pathways. So what is this pathway? So the type 1 interferon response is the first line of defense we have against viral infections. So when cells, such as in particular plasmacytoid dendritic cells, are exposed to virus, they secrete type 1 interferons that bind to interferon receptors on other cells and induce the expression of hundreds of different antiviral genes that suppress the replication of all sorts of different viruses. This is our first line of defense against viral infections and kicks in before the adaptive immune system. The problem is a key element of immune dysfunction in older adults is a deficiency in this type 1 interferon response to viruses. This has been shown by multiple groups, and we've reproduced it internally. But for instance, in this data on the left, investigators took males and females who are 20 to 35 years old or over 50 years old, isolated whole blood, and exposed it to herpes simplex virus. And you can see the younger adults made significantly more interferon in response to the virus than the older adults. And similarly, in the study on the right, these investigators took monocytes from young or old adults, infected them with influenza, and you can see the young monocytes make more interferon than the older monocytes. This deficiency in type 1 interferon response is probably one of the reasons COVID-19 is so severe in older adults, because this plays a critical role in fighting COVID-19. So we said, all right, if we're finding that mTOR inhibitors unexpectedly upregulate this interferon-induced antiviral response, maybe we can use them to protect older adults from viral respiratory tract infections. And in most of these studies that I'm going to show you, we use the catalytic site inhibitor called RTB101. What's interesting is to induce this interferon response, you only need to use 1/120th the maximum tolerated dose in humans, so it's been very well tolerated because it's a tiny dose. So we've done a large phase 2b and phase 3 trial of this drug to decrease the incidence of viral respiratory tract infections in older adults. The phase 2b enrolled 652 older adults, and we met the FDA's requested primary endpoint of decreasing the percentage of subjects with lab-confirmed respiratory tract infections. But at our end of phase 2b meeting, the FDA said this was pre-COVID-19. This is new for us, developing a drug that improves immune function, and we think for the phase 3 trial, no one in the real world gets a nasopharyngeal swab when they get a respiratory tract infection. So we want you to just decrease respiratory tract infection symptoms and don't do any lab confirmation for your primary endpoint. And as all of us know now, during the COVID-19 pandemic, it's really tough to know when you are feeling sick, whether it's due to COVID or not, without doing a nasopharyngeal swab. So this turned out to be a really difficult endpoint, and we missed the primary endpoint in this trial. It was really disappointing, but the good news is we've learned a lot that I think is going to help the field move forward. So first, we've learned that targeting aging biology with low doses or intermittent doses of mTOR inhibitors is actually well tolerated in older adults and really needs to get explored further in multiple indications. Second, in every trial we have looked, with every mTOR inhibitor, we are showing that low doses of mTOR inhibitors upregulate this interferon-induced antiviral response. Third, we think we've probably had the wrong endpoint in these previous trials. And I'll show you the data, but it looks like severity rather than incidence of lab-confirmed respiratory tract infections may be the appropriate endpoint for future trials. Fourth, I'll show you the data. We think that mTOR inhibitors are likely to have virus-specific effects. They work better for some viral infections than others. And fifth, it seems that the oldest of the older adult population, the people 75 and above, are the people who respond best and have the greatest treatment benefit. So first, just looking at the lessons learned about antiviral response, we looked at the expression of 20 different antiviral genes in whole blood during 16 weeks of mTOR inhibitor treatment or placebo treatment in both the phase 2b and phase 3 trials. And you can see most of these genes increase in expression in people who get RTB101, but not in placebo. So what are these genes that increase? Well, this is the replicative cycle of a virus such as coronavirus, and these genes with the red stars are the interferon-induced antiviral genes that inhibit all sorts of different replicative steps in the life cycle of all sorts of different viruses. And these genes highlighted in green are the ones that are consistently upregulated in older adults getting low doses of mTOR inhibitors. So what's the benefit of upregulating those genes? Well, we looked at both the incidence and severity of respiratory tract infections as pre-specified endpoints in the phase 3 and the phase 2b trial. If you look at the incidence of RTIs of any severity, mild, moderate, or severe, a 31% reduction was seen in people who got RTB in the phase 2b, but only 11% in the phase 3. The phase 3 actually was underpowered for this endpoint because the incidence of lab-confirmed RTIs was 50% lower in the phase 3 trial than in the phase 2b in the placebo group. But if you then start looking at RTIs with severe symptoms, you get a increased treatment effect in both the phase 2b and the 3 trial. If you look at hospitalizations for respiratory tract infections, the most severe infections, the numbers are too small to assess statistical significance, but a 74% reduction in the 2b and a 50% reduction in the phase 3. So moving forward, we want to look at severity rather than incidence of respiratory tract infections as the primary endpoint. Then the FDA asked us to look at the number of severe respiratory tract infections, caused by specific viruses in each trial. So you can see, this is a busy slide, but it's the number of severe infections caused by specific viruses in the RTB treatment group in blue or the placebo treatment group in gray. And you can see in both the phase 2b and phase 3 trials, we had decreased numbers of severe coronavirus infections in people who got RTB101, as well as decreased numbers of severe rhinovirus and influenza virus infections. But other infections like metapneumovirus, we didn't see any treatment effect. What's interesting is the viruses highlighted in green have been reported to suppress the host interferon responses. So these are the viral infections where patients may get the most benefit of upregulating the interferon response with an mTOR inhibitor. And last lesson learned, and this may be more generalizable in the field, we pre-specified looking at the oldest of the old in the phase 2b trial. So we looked at the treatment effect of RTB101 on the incidence of lab-confirmed respiratory tract infections in people greater than or equal to 85 years old or less than 85. And you can see there's a much bigger treatment effect, a 66% reduction in lab-confirmed RTIs in the oldest age group compared to the younger age group. In the phase 3, we didn't have enough people over 85 to analyze, so we looked at people 75 and above. And again, the treatment effect was greater in this older age group, 43% reduction in lab-confirmed RTIs versus only 6% in people 65 and above. Or I'm sorry, less than 75. So it may be that people 65 to 74, many of them may have a relatively normal interferon response, and isn't until you get to the older age groups where there's a more homogeneous deficit in this response and where you see treatment benefit. So taking all these lessons learned, we said after the failed phase 3 trial, let's test a different endpoint based on these lessons learned. Let's look at severity rather than incidence of a respiratory tract infection caused by a specific virus, coronavirus, in the oldest of the old, the nursing home residents. So we did a clinical trial of RTB101 prophylaxis to decrease the severity of COVID-19 in residents of nursing homes experiencing a COVID-19 outbreak. The average age of the subjects was 82. It was just a small pilot trial. 18 people were treated with RTB101, 17 with placebo for 4 weeks during an outbreak, and then they were followed for another 4 weeks. The FDA prescribed primary endpoint to assess the incidence of severe COVID-19 was the percent of subjects who developed laboratory-confirmed COVID-19 with protocol-defined progressive symptoms, hospitalization, or death. Here's the results of the trial. In the placebo group, 4 out of 17 subjects developed severe COVID-19, 2 died, and no one in the RTB101 treatment group developed COVID-19 of any severity. So this is a small trial that needs to be reproduced in larger, well-powered trials, but it gives us encouraging evidence that we may be getting closer to the right endpoints for trials of mTOR inhibitors in the future. So in conclusion, I think this program provides evidence that targeting aging biology to improve immune function of aging organ systems is likely to translate from animals to humans, and that's encouraging. And this program, the RTB101 phase 2b and 3 trials suggest that future clinical trials are going to benefit from a more targeted primary endpoint and patient population. And I think as a field, we have to understand there's going to be a learning curve for investigator sponsors and regulatory authorities when moving into these new endpoints, but we're going to learn from each of these trials and get better and better. So I want to thank my collaborators. A lot of this was done at Restore Bio, my previous company, and also support from the NIH and NIA. And that's it.
Thank you. Thank you so much, Joan. Thank you so much for this great talk. It's one of the most fascinating fields, also for me personally. Professor Barzilai joined us today after a difficult trip. Thank you so much for being here. Thank you for being in Copenhagen and with us. Professor Barzilai, for those who don't know, I don't think anybody don't know Professor Barzilai, but he's the leader of the TAME, metformin study, and the centenarians cohort. Professor Barzilai.
Terrific. So, yeah, about my trip, I hope you all believe in hormesis, because otherwise I was aging faster, okay? But if it was hormesis, I'm okay. The second point, and something that Jim said, but I came at the end. Is Jim here, Kirkland? Anyhow, look, what happens to us, this wave that happens for geroscience is absolutely incredible. And more than, and Alex and everybody, this is, right, this is a proof. Everybody wants to get to this field. I think we're really in a prime. And we don't have competition because there's a lot in this field. Okay, I remember when we started, everything was caloric restriction. It started to be a little bit crowded, but we're not there anymore. There's so many pathways, so many more hallmarks to discover that there's no competition. There's only excitement, and we all have to be friends. Okay, and the last thing is, you just heard those three incredible women. You know, at Einstein, Susan Horowitz is in the National Academy of Science. She's a professor emeritus. And I asked her one day, when you started like 50-something years ago as a professor at Einstein, and you're the only woman, how did you feel? She said, look, I knew two things. One is, I have to be twice as smart as men, and two, I have to work twice as hard. She said, it took me no time to discover that the first thing is not a big deal. And I think you just demonstrated that now. Thank you, guys. It's great to be under your leadership. Your charisma, excitement is really terrific. And now I'm going to do what, Eva, you told me to do. I'm just going to do, I have a relatively short presentation, just two provocations. I want to take two things that are related to gerotherapeutics. One is to drive the change of regulation, and the second, the transit to translational research. And I want to make two examples of them. One is related to the TAME study. The other is how do we do geroscience basically in humans? How do we prove in humans that we're talking about mechanisms for aging? And of course, our problem is that human lifespan was 17 to 35 years old throughout evolution, right? It's only the 150 years where we got into a disaster, right? All of a sudden, we triple our lifespan, and we got diseases that we never had before, okay? And we're accumulating them. And there's a bad quality of life, and it's up to us to create this new history now. Notice that a lot of the thing we did was prevention, right? Cleaning the water, building the sewer, doing vaccination. Okay, yeah, there was antibiotics and surgery, there's other things. But I think prevention is really what we should focus. We don't want to treat frailty and sarcopenia. Why should we? We should prevent people from coming there. And so when we are testing a gerotherapeutics, really what we'd like to do is to take a bunch of elderly people, to give them placebo or the drug that we're interested, and to see if in 5 years they have less mortality. That would be gerotherapeutics that affect lifespan. Is there something like that? Well, we know that metformin extends health span and lifespan in animals. And actually, there are several studies. I'll just show you the one that has a purpose. It's not the best study because it's an observational, it's a retrospective study. It's not a clinical study. But doctors gave patients with diabetes either sulfonylurea or metformin. Those are two options. The people that got metformin, by the way, were more obese, and they also had a worse glucose level. But in 5-year studies, the people on metformin had half the mortality of the people with sulfonylurea. But what was really interesting, what was really interesting, that they had the control of people who were treated in the same pharmacies by the same doctors, but who did not have diabetes. And the people who did not have diabetes had more mortality than people on metformin. The people with metformin were more obese, more diabetic, more sick with. And so it's obvious, a good question for us to ask, what happens if we give metformin to people who don't have diabetes? Do they have even less mortality? And this is the idea from a lifespan proposal, which I don't care much about lifespan. I think we should, and people said it before, we should talk about health span. By the way, this is the study itself. I just want to say UKPDS was a clinical study, okay? When metformin versus conventional treatment for diabetes decreased all-cause of mortality 36%, 42% for diabetes-related mortality, 36% for all-cause of mortality. This is just one of the other studies. So there are clinical studies that show that metformin had a mortality. I just want to say two things about metformin. Metformin, like almost every gerotherapeutic, targets all the hallmarks of aging. Okay? Really? Is it possible? Rapamycin does the same, okay? Well, this is what happens. If you take a real gerotherapeutic and you take an old cell or an old organ or an old body and make them young again, then you're going to fix a lot of things. The hallmarks are interactive with each other. You don't have to treat all of them to get effects on health span and lifespan. And I think that's what's going to with gerotherapeutics. We used to fight about that, but for me, if you don't get pleurisy here, this is not a true gerotherapeutic. So that's one thing to keep in mind. Second, and I'm just going over that, metformin in clinical trials also shows that it prevents diabetes, that it prevents heart disease, prevents cancer. Is not clinical trial, but it's a 250 associate trial. Cognitive decline is clinical study, and prevention mortality is clinical study. But what I'm telling you is that the study on what metformin is doing has been done, but on different populations, some diabetic, some not diabetic, but it hasn't done in one cluster that we can call aging. Of course, metformin is safe, has few side effects, generic, cheap. By the way, last week in New England Journal of Medicine, really a thing that's worth talking about later, but it's a study that tried 3 different medications to people with COVID, 3 days within COVID. 3 different medications, one of them metformin. The study was reported negative because the primary outcome was to see if it prevents hypoxia. And it didn't prevent hypoxia in any of them. But the people on metformin on secondary outcome had less hospitalization and less mortality, but by a lot. So it's a stupidity of us, in clinical studies that we build this, that, the idea that if primary doesn't work, then secondary is worthless, is wrong. We never thought that metformin will prevent hypoxia, but we knew, for example, that metformin makes the rest of the body makes the body resilient to a severe disease. That's also important for a gerotherapeutic. And there's a lot of articles. I'm actually not staying out of it, but there's lots of articles now in New England Journal pointing to this stupidity. It had power, it had everything. So what if your hypothesis is wrong or you didn't measure it? Okay, anyhow, The problem is that FDA doesn't recognize aging as a preventable condition, so the healthcare provider don't have to pay. Pharmaceuticals will not jump in and have better drugs and combination of drugs. And that's why we designed this study where we take elderly people, 3,000, double-blind controlled study, and from the FDA, okay, this is what we do with the FDA. We are agnostic. We don't know what diseases you have. We don't know what disease you're going to have. You're going to get point for any one of the disease, okay? If your mother was diabetic and you're obese, you're going to get diabetes, okay? But whatever you're going to get, we're going to monitor it, and we're going to show that in a 5-year study, we're going to prevent this disease, okay? This is a concept that's very hard to get, but the FDA has signed on it. And of course, it's also an opportunity to look at biomarkers, which is a big project. I don't want to talk more about TAME, but to say there's lots of important things for TAME, and you guys, the geroscience community, the biotech community, the pharmaceutical community, are all waiting for TAME. Now, the proof of concept, I don't care about. The reason we're doing TAME, metformin is a tool to get an FDA approval to something that is very, very close to aging. It's important for investors that are coming to biotechs because they know that maybe their gerotherapeutic can be tested. It's important for the discovery of biomarker. It's the template for pharmaceuticals to go on. It's part of the wave. Even announcing that TAME will happen is going to excite the field. And by the way, when TAME is done, it's a cheap medication that will be available initially. One thing, look, this ICD-11, that old age became an indication, backfired on us, okay? We all in this room, I mean, I claim aging is the mother of all diseases, okay? But that's not the same as saying that aging has to be a disease. When do we call aging a disease? I don't think we can call it a disease before we proved that we can do something about it in the clinical studies. Hypertension and cholesterol became an indication after there was a proof that if you decrease them, you're going to make a change. So this is a good debate to have. We have been isolated. By the way, the old age, the motivation for the WHO to change old age, because before that it was senility. And they said senility insults the people. Well, the elderly are very insulted to be called disease. Look what happened during COVID. We took the elderly and we isolated them and we made them lonely and they're miserable. They don't want to be called sick. So we have to think the people that we help are people that we need with us. The FDA we need with us. The ARP we need to us. The American Federation of Aging. We don't have a coalition. So let's cool down with aging and disease. We can go on, I think, without any problem. And the second thing I want to just make is, so there's more, you know, we just heard rapamycin. There's more than TAME-like information. Together with Felipe and George Kushel and several other people, we actually took all the drugs that have shown to increase longevity in animals and are FDA approved, and we made a system of up to 12 points. Actually, a new drug that's called SGLT2 inhibitor is really getting the majority of the points. It's a drug that we should notice. First of all, in the ITP, it increased lifespan of animals. It's here. I know it's not so clear. But in clinical studies, it decreased cardiac outcome, renal outcome, cardiac outcome, and all causes of mortality. Okay, it's a really, really strong opportunity for us to try and get them to be at gerotherapeutics as fast as metformin, pretty much. But the way that we are tying biology into, the biology of aging into aging is, and we've done it to resveratrol, metformin, acarbose, exercise, and metformin. We basically do small clinical studies. We take elderly subjects, and if they're not diabetic, we're taking them, and this is, by the way, the metformin example, because I didn't want to do too many other things, but we have, as I said, we have others. So 6 weeks, they are on placebo and metformin. At the end of that, we do biopsies from their muscle and adipose tissue where we get lots of kinds of cells. And then we do a washout period, and then whoever was on metformin goes to placebo, whoever was on placebo goes to metformin, and then we do other biopsies. There is a strength to that because everybody is his own control. So you don't know, it's a pair t-test analysis. You don't need to do large clinical studies. And the things that we're finding, first of all, of course, muscle and adipose tissue will have different transcripts, right? Because they have different purposes. But it's interesting that in the muscle, of course, pyruvate metabolism is the highest transcript, but it's not only metabolism, it's also genetic stability, okay? We depict the aging in those studies too. And it's the same with adipose. Yeah, biosynthesis of free fatty acid, but collagen stuff and, LXR and RXR and other indications. So with gerotherapeutics, we should actually see transcripts that is very, that hits more hallmarks. The second important thing, when you look at the mechanism that upregulates those transcripts, okay, you see aging. You see mTOR, MYC, TNF, TGF-beta. In other words, even if you don't see, my postdoc was very upset that he didn't find the one transcript that caused longevity, and you will find in all the tissues. But the upstream regulators are similar. We're coming up with a paper soon where we do a single-cell analysis. And the single-cell analysis is fascinating because not all the transcripts are regulated by metformin. Not in every cell, not in every tissue, metformin regulates. I bet it's going to be the same with rapamycin too. So it'll be important to know, and it'll be important to know because maybe we want to give different drugs at different possibilities. How many? Do I have 2 minutes? Please go ahead. I just want to make, this is an important point. We are assuming that if we get all the gerotherapeutics on top of each other, they'll be synergistic. I think, Eva, you gave a great example, right? The guy who took everything. I also have examples like that. Well, okay? I don't think we can be sure. And this is a cute example because the master trial took elderly and gave them exercise with or without metformin. Okay? And what they found that those on metformin had less muscle mass, significantly less muscle mass. They all gained muscle, but with metformin you gain less muscle. So they published the paper. In supplement 4 of the table, by the way, of the paper, they actually showed that there's no significant difference in the improvement of knee extension, maximal isometric contraction, power, relatively strength. For me, it says that this gram of muscle is much better, right? If you have less muscle and you don't have any force change, okay, it's much better. And indeed, we showed that the transcripts that are related to mTOR, and mTOR is what builds muscle, okay? The transcripts related to mTOR were decreased by metformin. On the other hand, with metformin, you had other transcripts that regulated autophagy, MAP kinase, cellular senescence, and other. So basically, there are trade-offs, okay? There are trade-offs, and there's some antagonism here. If you're young and you want to develop muscle, don't take metformin. By the way, I don't think metformin is good for young. That's another thing. There's antagonistic plerotrophy, right? What's good for you when you're young is bad for you for you're old. I think some of the therapeutics are bad when you're young. Metformin lowers IGF-1 level. I don't know that that's good, Also remember, this is looking at the muscle, but metformin, just like exercise, have so many other effects, okay, on health, okay? It's not only about the muscle. So that's it. So I think I talked about why we need to move with TAME. How can we link the biology of aging and clinical studies and really help us understand on humans what's going on? I just mentioned that not every gerotherapeutics may be safe for all or safe, and not all of them are safe in combinations. So let me again thank you for this exciting meeting. It's so great to be here, and good luck.
Thank you so much, Professor Barzilai, for being here, for giving us a fantastic lecture. We will expand on the discussion on germ protectors and therapeutics in the second panel.